our next speaker, Dr. Shreyas Ramamurthy. He belongs to that list which tells us that there is a wealth in the next generation who could very complacently beat the best out of us. And I'm sure the pearls which this young generation are going to come out with is something to be valued. On to you, Shreyas.
At the outset, I'd like to thank everyone at ARCIOS for the kind opportunity. Today, I'll just be presenting a couple of quick videos on cataract surgery with pseudoexfoliation. So we all know that preoperatively poor endothelial count, poor pupillary dilatation, and zonular weakness are some major challenges with PXF. Postoperatively, of course, IOP spikes, capsular phimosis, and a risk of corneal decompensation are ever present with all these pseudoexfoliation cases. So I'm showing a case of a 80-year-old male who had significant pseudoexfoliation with a grade 3 cataract and diffuse zonular weakness and phacodonosis. Although his endothelium clinically looked absolutely normal without any PXF deposits on the endothelium, which you might commonly see in some cases, the endothelial count was very low. So it's something very important that we should closely look at. So going to the surgery itself, I just go in and inject some trypan blue. And as you'll see now, creating that initial nick is quite difficult as there is a diffuse zonular weakness, and it's quite difficult to initiate the rhexis. I then do a small rhexis initially, and in these cases with diffuse zonular weakness, it's important that you don't start off with a large rhexis and go by a staged rhexis. And so I just make a nick in the anterior capsule, use micro scissor and forceps. Because the bag itself is mobile, this is the most difficult part. And while you're taking the rhexis along one side, the bag also tends to move with the rhexis as you're pulling on the capsular bag with the micro forceps. So doing a nick on one side, extending it on the other side, again doing a nick on the other side, and using a bimanual instrumentation to ensure you have a sufficiently large sized rhexis is exceedingly important. After that, do a gentle multi-quadrant hydro, not too exuberant, but at the same time, we want a very mobile nucleus. So before proceeding with the phacoemulsification, I insert 4 capsular hooks. It's quite important that these capsular hooks are placed before we do the phacoemulsification, before any additional zonular damage is done. Once this capsular hooks are in place, you can go ahead with your regular chopping maneuvers. It's a moderately dense cataract. It's important that the chopping is done progressively to ensure the posterior plate is cracked, but at the same time, the lateral separation should not be too much. So I evacuate a couple of pieces, and after that, I start seeing that the posterior capsule is also quite floppy and it is coming up because of the generalized weakness that is present. So there is no specific point of subluxation. There's no subluxation whatsoever, but there is a diffuse weakness. So at this point, I go ahead and inject a CTR, which kind of stretches out the bag and ensures that the posterior capsule does not come up, and you can continue to do a safe phacoemulsification. Advantage of waiting to insert the CTR a little later is while inserting the CTR itself, because a couple of pieces have already been removed, you have sufficient space to insert the CTR, and putting the second eyelet of the CTR, there's really minimal to no stress when you're putting in the CTR. So that would be the advantage of evacuating a couple of pieces and then inserting the CTR. And then subsequently, the phacoemulsification is quite uneventful. And yes, you have to keep, because of the poor endothelial count, ensure that it is a completely in the bag phaco, and use of high quality dispersive viscoelastics viscoat would be quite useful. I always prefer a 3-piece lens in these situations, because even though right now with the CTR and the 3-piece lens, the lens is very well centered and is more than sufficient, but these patients can over a long period of time go on to develop a further progressive zonulopathy and can have dislocations of these lens. At that time, the 3-piece lens can be converted either using a Yamane technique or the gludiol technique. This is a quick video. I have not much to show. This is just a PXF with a small pupil. What I want to reiterate here again, because of the higher zonular stress which can be there and poorer endothelial count, it's important that we have a large rhexis in place, and this can happen only if we have capsular hooks or iris hooks or iris expansion devices in place. Once you have a sufficiently large rexus, the phaco can then be done in a very controlled, nice manner, and IOL can be placed. The large rexus also ensures that the manipulation is very simple. There's no additional stress on the zonules, and subsequently, the incidence of capsular phimosis is also quite low. So after that, it's a routine phacoemulsification with an IOL in the case. So the take-home message is to really examine the endothelium closely in all these cases, probably do a specular in all cases of pseudoexfoliation. You'd be quite surprised to notice that the endothelial count can be quite low in some of the patients. Combined use of capsular hooks and CTR is always useful when there is a diffuse zonulopathy, but no specific point of subluxation. Iris hooks and pupil expansion rings, the larger rexus definitely reduces the zonular stress during your phacoemulsification, reduces incidence of post-op phimosis. Thank you so much for your kind attention.
Thank you, Shreyash. That was a wonderful teaching video, plenty of tips, and I think we have to force ourselves to ask questions. But having said that, don't you think, having seen the problems which come up with majority of these PXF cataract, if not right away over the years, that especially when we are doing a premium IOL, a multifocal IOL or a toric IOL, where the promises to the patient are more and decentrations are less tolerant, we should be placing a CTR in the first instance. Of course, you have in these, but there are many PXF cases where we do not. So,
in these kind of cases, I mean, with this kind of diffuse zonulopathy, I think I would keep away from all the premium IOLs. However, well, we do a good CTR, or if let's say if the zonulopathy was more than what I was showing in this patient, if there was already a subluxation present, even if we do a good CTS and anchor the capsular bag to the sclera, even then I think it is very difficult for anyone to be sure that 100% of the time they'll have a perfectly centered IOL. And I think that's imperative for a multifocal IOL. And therefore, I would stay away from premium IOLs in these patients.
Yes, I just want to ask you something. Excellent videos, both of them. Would you, like Chitra also asked, would you, because there are conflicting reports in literature, there's one study, randomized control trial, which has put CTR versus no CTR in premium and toric IOLs and found that there's no difference. There's another study which says, no, you should put CTR in all of the cases. So amongst all the people who are sitting here, how many put CTR routinely in all cases and how many don't put CTR and only put depending upon the cases?
I put CTR in all the cases,
One experience I'd like to share.
Is that what you're asking, madam?
1, 2, 3 hands I can see who put CTR in all the cases. 1,
because
2,
what happened in one
4,
of my cases?
5, 6, 7. 7 hands I can see. 8 hands are there who put CTR in all the cases.
Or that, or because they all want to say something. It could be that too.
One of my patient, I saw him 4 years after surgery. I had not put CTR. And when he came to OPD, he was having 6'9", and when we dilated, the whole back came in the AC and came to a counting finger. Then we had to do a scleral fixator. After that, I've been using CTR in all cases.
I don't think, although there is, I mean, CTR is useful. It's not that CTR is going to prevent the progressive zonulopathy from happening. So if this zonulopathy continues, and like you mentioned, sir, if the bag is really subluxating forwards and the IOL is coming into the anterior chamber, anyway, you would have to convert it into a scleral fixated IOL, or at least fixate the bag to the sclera using a Sione ring. So it is just, the thing is, it's variable. I don't think all pseudoexfoliation cases progress like that. We still don't know what percentage exactly would do it, though long-term studies have shown, including a recently conducted APEX study, has shown that pseudoexfoliation cases placing a CTR, the IOL centration seems to be good over the initial 5-year period at least.
I think nowadays we are seeing more cases of subluxation, the round, well-placed normal patient, because their life is long back, 10, 20 years back, we have placed the lens and they are coming with the subluxation without any reason. Have you any experience? All the panelists.
Capsular contraction is less.
Yeah.
If you put a CTR, that would probably decrease the amount of stress on the zonules. So the zonulopathy becomes delayed.
I have a very interesting observation, because many years ago I was using these Pharmacia Sion lenses with the PVDF haptic, and now I'm seeing many of them coming back with dislocation of the bag IOL complex. So I was wondering whether PVDF has anything to do with it, because there's no trauma or anything like that, and they come with spontaneous dislocation. And just these lenses, the incidence in these lenses are much more than the SI30 lenses or SI40 lenses that I'd used around the same time.
But
So I don't know if any of you all.
PVDF is supposed to have the best memory.
Yeah, best memory.
Memory, but whether does it have any effect on zonules and zonulolysis is something which because this is what I've seen.
Shri Ganesh, I have used these Sion lenses, thousands and thousands of these lenses, but I have not seen in any case subluxation or dislocation of the lens.
And just a couple of observations,
coincidence.
Exfoliation appears to be so common, and not all of them progress on to a problem in their lifetime. And I do not know whether it's really necessary to put it in each and every case, unless you find a loose bag, as was being demonstrated in those surgeries. And I feel that I have also seen these cases where the whole bag with the lens is subluxated. In those cases, if it's a 3-piece lens and you want to do a Yamane technique or fix it to the sclera, if you have an endocapsular ring in the bag, I feel that's going to make things more complex. I mean, what are you going to do with the endocapsular ring? That's one thought that comes to my mind. The other observation I want to make is, like in the photograph that Shreyas showed, where the capsular phimosis is quite severe. If you have pseudo-exfoliation, small people, you end up making a slightly smaller rhexis. In these cases, at the end of the surgery, it may be a good idea to nick the rhexis margin, create 4-6 nicks in different directions so that it doesn't go beyond the optic edge. But then that would really reduce the propensity for subsequent capsular phimosis from occurring.
I would also have one more point to share, and that is that in pseudo-exfoliation patients, if we make a slightly larger axis, it always helps to prevent a phimosis, and it also gives the zonules, they tend to be more relaxed. And putting in a CTR would only help to delay the luxation. So probably it's not a bad idea considering the cost of the CTR, and if you're using an injector, it's as good as injecting a lens in the eye. So probably it should be taken as a part and parcel of the procedure in cases of pseudo-exfoliation. I don't know what is the suggestion.
What does the CTR prevent? In every case, maybe you have just mild pseudo-exfoliation, absolutely stable bag. The patient is 60 years old and is going to live for another 25 years. What does the CTR do to the patient?
Yeah, so the CTR, what it would do is it would stretch the bag a little more, and thereby it would prevent the tension on the zonules, because many times, because of the surgery itself, there is phimosis, there is capsular contraction. So that contraction gives more chances for the zonules to give way. So probably that's the...
CTR is supposed to improve the circumferential support of the capsular bag. Supposing there are certain areas where it is loose, certain areas where it is a little stronger. This is supposed to distribute the forces quite circumferentially. So if there's diffuse zonulopathy over 10, 20 years of the lifetime of the patient, the whole bag is going to get displaced. I do not think the CTR is going to do anything to it.
No, so it only delays it. It doesn't prevent the subluxation totally.
Thank you very much.
One question.
Can I comment?
Our suggestion is anterior capsulotomy in the earliest stage of the phimosis. We make a cruciate for anterior capsulotomy will not help prevent from.
We can do it with the
capsulotomy in early stage. If we keep them in follow-up and do the capsulotomy in early stage, because anyhow this lens is going to, we have to remove this lens. If we can prevent it
is better.
Thank you.
So if this patient keeps more in the follow-up and do the capsulotomy, anterior capsulotomy in early stage, we may prevent some cases of subluxation.